managerial again in paediatric respiratory at Evelina London Children's Hospital. Did some more study, completed an MSc, had a family. Don't necessarily recommend doing those in tandem, by the way. Do not follow my example in that respect. Went higher up into that clinical managerial period. Nothing was really shouting education at this point, but I had always loved taking students, and I loved my clinical leadership role because I had so many rotational staff come into my specialty area. We got everyone being upskilled and trained in being competent on treating the little babies out of hours. And so this, strangely, from a very clinical and leadership space, moving into an education role fit very nicely for me. And I've moved up into other roles in that place. So I am a clinician by heart. I'm a physio by trade. I understand what it is like to follow that full clinical career pathway. I just happen to have had a very beautiful sidestep into this NHS England education space. So what are we going to be covering today? Some legislation, some policy, some strategy. I'm going to try and make it as entertaining as possible. I have some colourful pictures. We need to think about why we need educators. For those of us in the room, it may seem very evident, but to your chief financial officers, it is not always so. We're going to really do some focusing around the AHP Educator career framework. I know that's what some of your workshops later are based upon, and then look at what different levels of clinical management might benefit from using it. So I hope that fits a brief that you were expecting me to talk to. When it comes to education, this is our cornerstone. It is set out in law that our employers must give us the support, training and professional development, supervision and appraisals that are necessary for us to do our role. It is not good enough for someone to say, oh, we'll just postpone that. We're really busy. And it's not good enough to assume that we learn how to do these things just because we've had them done to us. Being an educator and a supervisor does not come to us by osmosis. It is not something that you can just see one, do one. And that is the cornerstone, that legal obligation of our employers to make sure this happens properly is why we need to be really good at our jobs as educators. We also have the Educator Workforce Strategy. It's written in fairly medical language, but very much applies to us as AHPs as well. And it states really clearly that delivering our future workforce is ultimately dependent on sustainable and, listen to this, high quality educator workforce. Again, we can't just give it to the person that kind of likes it and squeezes it in here and there. And you will see that educator workforce strategy, I've put the priorities in that colourful wheel, and it has enabling protected time in there. We know so few AHPs get that protected time to deliver and receive education. You know, we have got that number 4 is supporting the development and well-being of educators. How often do we get developed as educators outside of this wonderful day that you are attending right now? You know, there is pure NHS England strategy that is telling us these things need to happen for us to have a workforce that is fit for the future. We also have the AHP Educator Career Framework, and we're going to go on to that in a moment. Having professional development frameworks for educators is the third priority of the Educator Workforce Strategy. And here you can see that it's an outcome-based career framework, and any of you that are used to undergraduate curriculum, a number of our therapies are based on outcome-based progression. And it promotes that education pillar of practice for all our AHPs. But I really want you to look at that final few words. Education is everyone's responsibility. You may have some people that really decide to foreground in that education pillar of practice. The role that I'm doing now, the role that I'm going to go on to in the future as an AHP education lead, most of what I'm doing is education. But even our Band 2 support worker that works on our care of the elderly ward should have some element of education written into their job description. Anyone that counts themselves as an AHP should have education as part of our portfolio. It may only be a small amount. It may be to our peers, it may be to junior staff, it may be to students, but everyone should have it somewhere within their job description because it is everybody's responsibility. So when we're looking at that AHP Educator career framework, it can't be that, oh, I'm the educator, I'm going to take all of this away from you. You don't need to worry yourself about it. Our job as AHP educators is to empower and enable that ripple effect so that everyone else around us can become a better educator as well. So why do we need AHP educators? Well, I've already spoken somewhat about the 4 pillars of practice, and to be an AHP professional, we should have a level of development across all of them. It is part of our professional responsibility to be educators. It's also in our standards of proficiency. So, when it rolls around and you've got to sign the little form to say, yes, 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 I'm still completely appropriate to be on the HCPC register, and you cross your fingers and hope that little letter doesn't come that says you need to share your CPD portfolio of evidence with them. It says in there that we need to be acting as role models for others, which is exactly what educators do. And it says that we are responsible for promoting and engaging in the learning of others. So this is not something that can be given to a small subsection of our AHP community to do. It is the responsibility of us all. But there are also amazing opportunities for those of us that love education to do more of it, to do it better, and to work out why it is brilliant. I'm going to go back to the real core initial bit that I began to speak to you about. Why do we need educators? We need them to deliver high quality care. How do we learn how to treat the real complex patient if we don't get someone more experienced than us explaining that to us? How do we give a really patient-centered experience of the care that we provide if we do not have people that have walked that path before us telling us how to do it right? Asking us those questions of, for your profession, for the patients you're seeing right now, what does quality mean to your patient? And quality will mean a different thing to each of our patients. For some, it may be in speed. For others, it may be amount of time. For some, it will be about how good those conversations you have with them, working out their goals and those problem solving will be. Quality is not one thing when it comes to AHP. But if you are going to be an educator, you need to work out what are the quality metrics for the area you are educating in and collect them. You need to say, okay, we are bringing education more to the forefront of this service we are offering in outpatients. Have a look and see what change you think that education initiative is going to deliver, and look at those quality metrics, whichever are the ones that are important at the beginning and the ones that are at the end, for either our staff or our patients, so you can prove that education works. Because unless we're beginning to prove that education works, those CFOs, those service leads won't necessarily invest in it. So it is our responsibility as an educator to make that link with quality. It is also really key that we make that link with health and safety. I don't know whether any of you have ever had the responsibility of putting in a datex or analysing a critical incident that's happened and making recommendations on the basis of it. But I can almost guarantee you the vast majority of them will either find the person that did the datex and was responsible for it either hadn't had the supervision they required, or hadn't had the training they required, or when we're looking at what we're going to do to fix the problem, oh, we'll put up an information poster where everyone can see it, or we're going to train everyone about how to use this new checklist to make sure that thing doesn't happen again. At the heart of a lot of our mitigating actions to risk, education is at the core of it. But when does that get logged? Who frees up the time to do that education? How do we know that education is going to work? When do we evaluate it to make sure that that risk hasn't happened again? And again, it is for us as educators to make sure we're really articulating that link clearly and showing that we are providing a benefit that is above and beyond the nice to have. We also know that educators improve productivity, and that is not by asking staff to see another patient or work harder, because we know that everyone is working to that most they can do at the moment. We can't squeeze another patient in. We're not getting our lunch breaks as it stands. But what education enables you to do is to see more complex patients without asking for that second opinion or double checking with someone senior. It enables you to know how to do that risk evaluation. Can I discharge this patient? Is that a viable risk? Yes, we're never going to be able to take away that fool's risk 100%, but have we done all the mitigations? And am I assured of that? Because I'm educated well enough to make those decisions. As we upskill our band fives, our band sixes, those people going through that preceptorship, that foundation, that enhanced level, to be educated and well trained to make those risks, to deal with that complexity, you are automatically going to get more productivity because there is less double checking and they're available and appropriate to see more patients. How can we make that clear, articulated risk about us being educators and doing that well into how we are running services better? Because that's when we become important to people. We need to stop being the nice to have. Education needs to stop being the thing that someone says, oh, we just don't have time for it. Oh, this emergency has just happened. There will always be an emergency with the NHS. It's how we run. How do we prove that gatekeeping the time for us to deliver and receive education that is high quality and well evaluated, that we know it does the right thing, becomes so integral to how we deliver high quality care that people stop making it the nice to have. And some of that's about what we do. It's got to stop being like, oh, my student really liked me. Actually, it's nice your student liked you, but did they decide to fill your band 5 vacancy and start working in your organisation? It's got to stop being, oh, I had 10 people come to my course or my CPD session I ran. It's got to be, I ran a session on this really niche, complex patient group of this condition that only comes up in every 100 days. But you know what? Those band sixes didn't have to contact me and didn't have to wait 3 days for me to come back from my annual leave to treat that patient because they understood that condition. And 6 months later, they retained the information and were able to treat that patient appropriately. Those are the metrics that matter. It has got to stop being the nice to have. And I'm going to go back to that point of the AHP Educator career framework, that all of life is education and everybody is a teacher and everybody is forever a pupil. This has got to stop being siloed. I do this thing to you. This has got to be inbuilt into a pathway of lifelong learning for everybody, where some people will do more of it and some people will do less of it, but all of it has to be done well. I'm now going to move to talking slightly more specifically about the AHP Educator career framework, because I know that's what some of this is focused on. So where does it come from? It was published by the Council of Deans in 2023 as a commissioned piece of work from NHS England, from the Chief Allied Health Officer's Professions Office. And it has got 6 guiding principles, and that's those grey circles you can see around the outside. And then it has got 6 domains within the inside, and you'll see that those coloured domains are what we're really going to focus on. And it is really looking at linking it to AHP's Deliver, which is another key strategic document for those working in leadership in the AHP space, needing to embed a strategic approach to leadership in AHPs. The first principle of People's First really is about career progression that's guided by organisational as well as individual requirements. The quality, diversity and inclusivity, well, that should be through everything we do. That really has got to be a golden thread through any education, but it really is underpinning that commitment to the AHP workforce throughout all career stages, that it is inclusive and everyone feels like they belong in that space. Number 3, education for all is about that lifelong learning I've already alluded to, and supporting others to be supported by others. throughout the career journey, how we as educators can have that ripple effect to empower others to deliver education so it doesn't just rely on a small subset of our community. It's about individual and team development and advancement of AHPs as a career journey for all. Community-centred is about that co-production piece. It's about making sure that the education we are providing is fit for those that we are educating, be they peers, be they junior staff, be they patients. Inclusive learning is really linked, although it was written different from the Safer Learning Environment Charter. I'd see those two pieces in absolute counterstep with each other, about how we ensure that people can learn, can bring that vulnerability to the table, can have psychologically safe spaces to explore where they may not feel confident in their knowledge. And then 6 is multi-professional. We as AHPs often work so well multi-professionally, although sometimes the therapists do it better than the rest of the AHP groups. We need to bring everyone together a bit better in that space. But the framework has really been developed through a multi-professional lens, which means it should not focus on one AHP group more than others. And you can see there the AHP delivers principles and how they linked. You can see the language is really echoed between those two documents. The framework is defined by AHP career stages, and you may find that some of you agree with this and some of you don't. But it is essentially looking at students, learners and apprenticeships, followed by support workers and advanced support workers, or those assistant practitioner roles. Then you've got your early career graduates, so those looking at that 1 to 2 year space. Mid-career graduates, some people would say the 3 to 5 year space is a mixture between that foundation and enhanced space, and then look at those that are senior clinicians or enhanced practitioners, so those that have been qualified for 5 or more years. But we also know and need to recognise when we're looking at this document that you may be very advanced in your clinical knowledge. You may be an absolute expert radiographer that can do MRI and CT without blinking an eye when most people are petrified of those modalities. But that does not mean you feel confident or experienced in the educator space, and that may be a skill set that is newly required of you. So sometimes where you are clinically is not the same as where you are as an educator, and that is A-OK to recognise that and develop within that scope of practice you have. So remember, just hold those two pieces differently. When you go into the document, you will see this for domain 1. And it's probably easiest if I talk you through as if we were a certain level. So let's take the mid-career graduate, because that might kind of encompass a lot of people understanding where that space is. You can see through the medium blue dot boxes in there that you should be taking part in observed teaching and other activities. You should be participating in regular peer review. You should be having comprehensive session plans, adhering to the principles of inclusivity and keeping appropriate records. So you can go through and be like, oh, that's something I can do. Oh, I didn't realise I was meant to have peer review of my teaching. I hadn't really thought of that. How can I enable that? That might be something I want to work on. So this is how you can really use it to map what you should be doing against what you are doing and where that skills gap is. You can see that similarly for your diverse and inclusive education leadership. So if I look all the way across, okay, I don't really need to be leading teams education at this point of time. And whilst I've got something we can see from earlier on about that promoting diverse learning inclusion, actually, I don't need to look at it much more broadly across a wider group of professions or a wider group of education stages. I don't need to worry about those bits right now. With community and co-production, I should be providing appropriate feedback on learning. Oh yeah, I do that. I fill in those feedback forms when someone gives me a CPD session. Oh, but maybe I hadn't really thought about co-production of my teaching resources. But I do design and develop materials that are culturally relevant because I've been on that training. I understand how to do that. But maybe I don't evaluate the effectiveness of the teaching. I ask people if they liked it afterwards, but I've not done that piece where I've looked 3 months later, have they remembered anything I said? Again, in that foundational skills and knowledge, you don't need to worry about those first two columns, but you really want to be looking at how you can succeed in those other capabilities along that layer. Domain 5 is about digital and sustainability. And this is about what you need to do for your professional responsibility, but also really recognizing how we need to make education sustainable. It can't just be you, the only one that's able to develop and deliver that teaching in that environment. How can you upskill other people to do it? If you got called off sick and had to go to hospital for 4 months, if that education's needed, it can't be that it just falls off the cliff. How do we build sustainability in? Is there a talked over PowerPoint on the shared drive? Can someone else mentor someone through these? How do we build that into what we're delivering as educators? And then research and quality improvement to some people might look a little bit scary, but it shouldn't be, because so much of this should be filled in your professional obligations and you should be doing anyway when you're looking at your PDRs and that research pillar of practice. We're just linking it with the educator piece. They do have an academic qualifications framework here where they look at having a form of accreditation, having a badge that we as AHPs can say, yes, I'm educated at a standard that is high enough to be nationally recognised, in fact, internationally recognised. What's really interesting here is they're advocating for this even for support workers. I do think this is a brilliant aim to have, but we just need to be a little bit careful because there are costs that are involved in this, and you need to have really good links with your local academic institutions because you need an academic reference to apply for this. I'm going to hold the slide up a little bit so people can take note of those QR codes if they want to. But these take you through to the Advanced HE website, which explains what all those different models are. So the top QR code is the Advanced HE, explains what it does, why you might want to have those accreditations and affiliations. The bottom one should take you to their tool. So you can actually fill in a tool, an Advanced HE, say what your roles and responsibility are to education, and at the end it will spit out which of its fellowships you should probably apply to. So just useful information for you to have there in this space. They also have on there what you might want to be getting as far as education for your level of practice. And what's really interesting is that here you can see that they've suddenly put in head of education and practice learning facilitators, which is not a role that is talked about in anywhere else in the rest of this document. But if you are doing any of those roles, this is a really nice space to be like, no, this is recognised in the AHP Educator Career Framework. Again, you need to think, if you are a mid-career or senior clinician, really wanting to go down that clinical pathway, and there's only a certain amount of money to do level 7 master's postgraduate qualification, whether you'll choose to do that in a clinical specialty or whether you'll decide to do a PG cert. And they're really hard decisions to make as a professional because often we only get one shot at doing that. But this really does advocate for people becoming more advanced in their careers, recognising that educator pillar of practice and getting that level 7 upskilling in it. So ultimately, that's nice, Ellie. You've shown me a load of coloured boxes. The typing was a little bit little and I couldn't really see what was in it. And I'm going to have to go and refer to the document that I know Geraldine sent me on the way to coming to this course. What do I do with it? So as an individual, this is what you can do with it. It can promote you to see where you want to enhance your education pillar of practice. It enables you to do a bit of a self-assessment. You can use it as part of your PDRs, your personal development plans. You might actually say, oh gosh, I hadn't realised that coaching was a big part of being an educator. I also really need to coach a lot of my patients and how they can give up smoking. And I'd much rather use a coaching effect to do that than a wagging my finger at them. And if you do this and you do get called to that HCPC audit, it can be used as really good evidence that you're looking at your skills and how they map to those requirements of the HCPC standards. As a line manager, it can give you oversight to prioritise the education and pillar of practice for your team, maybe audit your team against education quality, have some really good team focused conversations around education, begin generating a skills gap analysis. So it may be that you want some upskilling to be brought in for everyone for your team. You can really input then into how education ensures safe and effective care at that team level, that narrative I was talking about, making those lines really explicit, and use it as a launch pad to discuss what activity should you be having, what capacity do you have for education, what demand do you have for it from a rotational staff point of view and learners and apprenticeships coming through the team. And then organisations can use it to look at some support overall for the workforce in the education of pillar of practice, looking at setting of standards, changing culture towards education, enhancing that organisational learning environment alongside that safer learning environment charter, really having a standardisation of approach and transparent career pathways that follow the skills need outlined in it. You can really champion excellence in education and have it as a strategic framework to inform partnerships amongst your systems between your FE colleges and your HEIs to see what you can get within an HEI providing you some upskilling, but you may be providing some staff to deliver lectures, and how can we get that cross-pollination and advancement for everybody? So I'm very sorry, I've very slightly gone over my time, but essentially what I want you to remember, if there's only 5 things, all AHPs are educators. If you have protected time to do it, then make sure you're making other people better educators. But without AHPs identifying and acting as educators, especially for our undergraduate students and apprenticeships, we won't have a future workforce. You will not be able to fill your Band 5 posts. And essentially, we need to ensure that we articulate how AHPs working as educators enables us as services and individuals to deliver better quality care, safer care, and enables our teams to be more productive because they are smarter and more able in doing things, not because they necessarily do more. I encourage you all to be excellent AHP educators. Any questions?
Thanks, Ellie. Hopefully you can hear me. Just to say thank you. You were absolutely worth waiting for, and I'm so sorry we had our technical hitch this morning, and thank you so much for bearing with us.